We'll be breaking down all major concepts covered on the exam. I'm your host, and I'm really excited to get into this one.
And I'm your expert MCCQE reviewer. Our whole focus today is giving you, the listener, an absolute edge on test day.
Yeah, exactly. Because when you look at gastroenterology and specifically diseases of the liver, the diagnostic landscape can feel just incredibly murky.
Right, it's not a simple binary. You aren't dealing with, like, a broken bone on an x-ray where the pathology is obvious.
I know, it's tough. You are dealing with complex, overlapping presentations. So our mission for this deep dive is to distill these high-yield liver pathologies into a physiological framework. We want you to understand the why behind the symptoms.
Not just memorize a list of facts,
Yeah.
right? And to set our foundation, the material we are unpacking today comes directly from reliable StatPearls articles.
Super important to note. And we also need to state clearly right up front that this deep dive is for medical education only, not medical advice. Any clinical decision should always involve a qualified healthcare provider. So I want you to treat this deep dive like a structured, high-yield clinical rounding session. We are going to build this from the ground up. Before we investigate the specific viruses or, genetic mutations that destroy the liver, we first have to understand the mechanical endpoint. We need to understand the plumbing.
The plumbing, yeah. The hemodynamics of liver failure are usually what make chronic liver disease fatal. Regardless of the underlying etiology, when the liver architecture is completely destroyed by fibrosis and regenerative nodules, well, you develop portal hypertension.
Right. And I used to visualize portal hypertension like a traffic jam on a highway, but that analogy actually falls short because it implies a static blockage.
Yeah, it's much more dynamic than that.
Exactly. A better way to think about it for the exam is like a kinked garden hose in a high-pressure system. The blood from the splanchnic circulation is still being pumped in, but the outflow tract through the liver is severely restricted.
Which causes this intense hydrostatic pressure to build up behind the liver. Normal hepatic venous pressure gradient, or HVPG, is 5 millimeters of mercury or less.
Okay, so 5 is normal.
Right. Portal hypertension technically begins at 6. But the clinical threshold you absolutely must remember for the boards is 10 millimeters of mercury.
10, got it.
Because when the gradient exceeds 10, the pressure is so immense that the body starts opening up collateral vessels to bypass the liver entirely. That is when you see esophageal and gastric varices form.
Which carry a massive risk of life-threatening hemorrhage.
Exactly.
And the mechanism behind that pressure buildup is where things get really interesting, I think. It isn't just physical scar tissue blocking the flow. The body actually tries to fix the problem and ends up making it substantially worse.
Oh, totally. As resistance in the liver increases, the endothelial cells release massive amounts of nitric oxide.
Right, which causes profound splanchnic and systemic vasodilation. The vascular bed widens so much that the blood essentially pools in the splanchnic circulation.
And that drops the patient's systemic blood pressure. The baroreceptors in the aortic arch, they sense this drop and basically trick the brain into thinking the patient is bleeding out.
Even though their total body fluid is actually overloaded.
Exactly. So the kidneys panic. The juxtaglomerular apparatus fires off renin, triggering the renin-angiotensin-aldosterone system.
Aldosterone just floods the system, forcing the kidneys to aggressively reabsorb sodium and water. I mean, the body is desperately trying to fill a vascular bucket that has essentially expanded to twice its size.
And all that extra fluid just feeds right back into the splanchnic system, hitting that kinked hose of the fibrotic liver. The hydrostatic pressure becomes overwhelming.
So fluid begins weeping directly off the surface of the liver and the splanchnic vessels right into the peritoneal cavity.
Which we call ascites. It's the most common complication of decompensated cirrhosis.
Okay, so when you have a patient with massive ascites on the exam, you have to sample that fluid. The test they always want you to interpret is the SAG score.
The serum ascites albumin gradient.
Right, the SAG. You calculate it by subtracting the acidic fluid albumin from the serum albumin in the blood. If that gradient is 1.1 grams per deciliter or higher, you are looking at portal hypertension.
But why do we care about this 1.1 cutoff instead of just, looking at total protein?
Yeah, that's the classic board question.
It's because the SAG score is a direct reflection of Starling forces. In portal hypertension, the hydrostatic pressure is so high that it acts like a sieve, pushing an ultrafiltrate of water out into the abdomen.
But the vascular endothelium is still relatively intact, right?
Exactly. It's under pressure, but intact. So it traps the large, bulky albumin proteins inside the bloodstream.
So your serum albumin stays high, the acidic fluid albumin stays very low, and the mathematical difference between them, the gradient, is wide. It's 1.1 or greater.
And that wide gradient predicts portal hypertension with 97% accuracy, whether from cirrhosis, right-sided heart failure, or Budd-Chiari syndrome.
But if the SAG is less than 1.1, the gradient is narrow.
Right. That tells you the capillary walls themselves are damaged or inflamed. They're allowing large albumin molecules to leak out alongside the water. A narrow gradient points to peritoneal carcinomatosis, TB, or pancreatic ascites.
Let's translate this hemodynamics lesson into a clinical management trap for the exam. Picture a 60-year-old patient admitted with tense ascites. They're carrying an extra 10 liters of fluid in their abdomen.
That's a lot of fluid.
It is. My instinct as a junior resident was to just, push 80 milligrams of intravenous furosemide and force the kidneys to pee it all out quickly. Why is that aggressive loop diuresis the absolute wrong move?
Because hitting them with massive doses of furosemide alone will rapidly deplete their intravascular volume. Remember, the primary driver of their fluid retention is secondary hyperaldosteronism.
Oh, right.
If you deplete their blood volume too fast without blocking the aldosterone, you will severely underperfuse their kidneys. That precipitates hepatorenal syndrome, which is often fatal.
So the board-tested regimen reflects that underlying pathophysiology. You have to block the aldosterone first.
Exactly. The gold standard is a combination of spironolactone paired with furosemide in a strict 100 to 40 milligram per day ratio.
That exact 100 to 40 ratio is critical because it balances the potassium, right? Spironolactone holds on to potassium, while furosemide wastes it.
You got it. Together at that ratio, you pull off the fluid while maintaining normocholemia. But you must also pair this with a strict 2,000 milligram per day sodium restriction.
Otherwise, the kidneys will just hold on to whatever sodium the patient eats.
Exactly. Now, sometimes the ascites is so tense it impairs their breathing, and you have to perform a therapeutic paracentesis. You drain 5 or 6 liters of fluid from the abdomen.
And the clinical trap here is post-paracentesis circulatory dysfunction.
Right. When you rapidly drain that much fluid, the intra-abdominal pressure suddenly drops. The splanchnic vascular bed expands instantly, causing the patient's blood pressure to plummet into cardiovascular collapse.
So to prevent this, for every liter of acidic fluid removed beyond 5 liters, you must simultaneously administer intravenous albumin.
It acts as a volume expander, pulling fluid back into the vessels to support their blood pressure.
Okay, that structural backup explains the final stage of liver failure. But to prevent a patient from ever reaching that point, we have to look at the primary insults that trigger the scarring in the first place.
The most common drivers we see in the wards, and definitely on the boards, are the hepatotropic viruses. Hepatitis A, B, and C.
Differentiating their serological markers is absolutely guaranteed to show up on your exam. Let's start with Hep A. It's an RNA virus transmitted primarily through the fecal-oral route.
Picture a local outbreak traced back to contaminated strawberries or oysters.
The golden rule for hepatitis A is that it never causes chronic liver disease. The body clears it, and it does not lead to cirrhosis.
While it doesn't cause chronicity, there is a specific presentation the exam uses to test your clinical reasoning. Up to 10% of adults with Hep A can experience a relapsing or prolonged cholestatic course.
The immune response causes severe inflammation of the intrahepatic bile ducts.
Right, so the bilirubin backs up. They're alkaline phosphatase spikes. They present with profound jaundice and intractable pruritus. They're itching intensely because bile salts are depositing in their skin.
And this can last for months, mimicking a mechanical biliary obstruction. You have to recognize that this is just a prolonged variant of Hep A, and it will eventually resolve with supportive care.
Moving to hepatitis B, we shift from an RNA virus to a DNA virus. It is transmitted via bodily fluids, blood exposure, sexual contact, and critically vertical transmission from mother to child.
Hepatitis B is dangerous because it can evade complete immune clearance and become a chronic infection. That's defined by the persistence of the hepatitis B surface antigen, or HBsAg, for more than 6 months.
I remember being absolutely terrified on my internal medicine rotation when an attending pimped me on the hepatitis B window period.
Oh man, the window periods. It's a massive pitfall.
A patient comes into the clinic with severe fatigue, right upper quadrant pain, and jaundice. You suspect acute Hep B. You run a viral panel, and the hepatitis B surface antigen comes back negative.
And a lot of students assume the patient is clear.
Right. But to understand the window period, you have to look at the kinetics of the immune response. When the patient was initially infected, their viral load was high, and they had detectable surface antigen.
But as their immune system mounts a robust defense, It begins destroying the virus, and the surface antigen drops below the detectable threshold of our lab tests.
And here's the catch test. Their body hasn't yet produced enough protective neutralizing antibodies to be detected either.
The anti-HBs.
Exactly. So you are left with a serological dead zone, the antigen is gone, and the protective antibody hasn't arrived. During this window period, the sole marker that proves the patient has an acute active hepatitis B infection is the anti-HPC IgM.
The IgM antibody directed against the core of the virus. If you do not check the core IgM, you will completely miss the diagnosis.
Now, if a patient transitions into chronic hepatitis B and requires treatment, our goal usually isn't a complete functional cure, but long-term viral suppression.
Right, we use nucleotide or nucleoside analogs, specifically encavir or tenofovir.
And the exam tests your understanding of why those specific drugs are first line. Hepatitis B replicates using a reverse transcriptase enzyme that lacks a proofreading mechanism.
So it makes billions of copies, and it makes constant mistakes, rapidly generating mutated, resistant viral strains.
Entecavir and tenofovir are used because they have an incredibly high barrier to resistance. They mimic the natural building blocks of DNA so perfectly that even the mutated viral polymerases incorporate them into the growing viral strand.
Once incorporated, they terminate the DNA chain, stopping replication in its tracks.
Which brings us to hepatitis C. This is an RNA virus, mostly transmitted through intravenous drug use or contaminated blood products.
It's highly insidious because, unlike hepatitis B, where most adults clear it, 80 to 85% of acute hepatitis C infections evolve into chronic disease.
Genotype 1 being the most prevalent worldwide.
I like to conceptualize Hep C treatment using a software engineering analogy. For decades, treating Hep C was like trying to fix a buggy computer by randomly hitting it with a hammer we used interferon.
Which caused brutal systemic side effects and had terrible cure rates.
Exactly. But modern direct-acting antivirals, or DAAs, are like a targeted software patch that finds the malicious code and deletes it.
They are molecularly engineered to jam the specific machinery the virus uses to replicate. DAAs target the viral non-structural proteins.
You have protease inhibitors targeting NS34A, replication complex inhibitors targeting NS5A, and polymerase inhibitors targeting NS5B.
It's like breaking a factory assembly line at 3 different stations simultaneously. The virus just cannot assemble itself.
The pharmacological success here is staggering. By combining these DAAs, we can cure 90 to 97% of patients in just 12 to 24 weeks, entirely without interferon.
Incredible, really. But viral infections are only one piece of the liver pathology puzzle. What if a patient comes in with rising portal pressure, ascites, and varices, yet their viral panels are entirely negative?
Then we have to look at endogenous threats. The two major genetic conditions the MCCQE loves to test are hemochromatosis and Wilson disease.
Both are autosomal recessive, and both cause cirrhosis through heavy metal toxicity. The key to distinguishing their clinical presentations in a vignette lies in understanding where the excess metal deposits outside of the liver.
Let's look at hemochromatosis first. This is a mutation in the HFE gene, usually the C282Y variant. The body absorbs uncontrolled amounts of iron from the gut, depositing it in tissues as hemosiderin.
The classic board presentation is the bronze diabetes triad.
Right. You have iron destroying the liver architecture to cause cirrhosis, iron depositing in the pancreas to destroy the beta cells and cause diabetes, and iron accumulating in the skin, causing a distinct bronze hyperpigmentation.
But beyond the triad, there's a fascinating and highly specific infectious disease trap tied to hemochromatosis. The human immune system relies on macrophages to phagocytize bacteria. But in these patients, the macrophages are engorged with toxic iron, impairing their function.
On top of that, there is a marine bacterium called Vibrio vulnificus that is highly siderophilic, meaning it absolutely requires massive amounts of free host iron to replicate.
The classic vignette will describe a patient with fatigue, joint pain, and perhaps mildly darkened skin, who eats a plate of raw oysters and suddenly develops fulminant, life-threatening sepsis.
They essentially provided an iron-enriched buffet for the Vibrio bacteria. Sepsis after eating raw shellfish in a patient with liver dysfunction points squarely to hemochromatosis.
To confirm the diagnosis, you look for a transferrin saturation greater than 45% and a highly elevated serum ferritin.
And the treatment is remarkably straightforward but effective: therapeutic phlebotomy. By regularly drawing the patient's blood, you force their bone marrow to make new red blood cells.
And to create the hemoglobin for those cells, the body must mobilize and drain the toxic iron stored in the liver and pancreas.
Contrast that iron overload with Wilson disease, which is an overload of copper. This results from a mutation in the ATP7B gene on chromosome 13.
This gene codes for a critical hepatic copper transporter. When it is defective, the liver cannot excrete copper into the bile, leading to toxic intracellular accumulation.
The defining feature of Wilson disease on the exam is its neurological and psychiatric presentation. Copper has a strong affinity for the basal ganglia in the brain.
You will often see a teenager or young adult presenting with resting tremors, muscle rigidity, dysarthria, or even sudden severe personality changes and psychosis.
You also look for Kaiser-Fleischer rings deposits of copper in the deciment membrane of the cornea, visible as a golden brown ring during a slit lamp examination.
But the ultimate hematological trap for Wilson disease is a young patient who presents with acute liver failure and a Coombs-negative hemolytic anemia.
Wait, why would liver failure cause their red blood cells to explode?
Crazy, right? When the hepatocytes become completely saturated and undergo necrosis, they dump massive quantities of free copper directly into the bloodstream.
Oh, wow.
Yeah, and free copper generates potent reactive oxygen species via the Fenton reaction. This intense oxidative stress targets the lipid bilayer of the red blood cells, making them brittle until they physically shatter in the microvasculature.
The Coombs test is negative because this is direct chemical destruction, not an antibody-mediated autoimmune attack.
Exactly. To diagnose Wilson disease, you look for a remarkably low serum ceruloplasmin, less than 20 milligrams per deciliter.
Because ceruloplasmin is the protein that carries copper. When the liver can't load copper onto it, the empty protein is rapidly degraded in the blood.
You will also measure massive amounts of copper spilling into the urine. Treatment requires aggressive copper chelation with agents like penicillamine or trientine, or the use of oral zinc, which competes with copper to block its absorption in the gut.
Let's briefly touch on autoimmune hepatitis, or AIH. This occurs when the immune system loses self-tolerance and mounts a T-cell-mediated attack on the hepatocytes.
The exam requires you to differentiate the subtypes based on their autoantibodies. Type 1 is predominantly seen in adult females and is characterized by anti-smooth muscle antibodies, or ASM, along with positive ANA.
It seems strange that liver inflammation would produce antibodies against smooth muscle, but as the hepatocytes are destroyed, intracellular cytoskeletal proteins like actin are exposed to the immune system.
The body mistakenly forms antibodies against these structural proteins, which is why ASMA is such a strong marker.
Type 2 AIH is much less common, typically seen in children, and is marked by anti-liver kidney microsome type 1 antibodies, or anti-LKM1.
For either type, a liver biopsy will show a very specific histological pattern called interface hepatitis, where the heavy lymphocytic inflammation spills out from the portal tracts and erodes the limiting plate of the surrounding hepatocytes.
Treatment relies heavily on suppressing that immune response, starting with prednisone and often adding azathioprine for maintenance.
So we have discussed the physical crushing of the liver from portal hypertension, the chronic replication of viruses, the toxic buildup of heavy metals, and the friendly fire of autoimmunity.
All of these chronic inflammatory states converge on one ultimate fatal complication:
Hepatocellular carcinoma, or HCC. It is the 5th most common cancer worldwide.
The pathophysiology is inextricably linked to the liver's constant cycle of necrosis and cellular proliferation. As the liver desperately tries to regenerate its tissue over decades, the sheer volume of cell division allows genetic mutations to accumulate,
Eventually spawning a malignancy. That requirement for chronic scarring is why almost all HCC occurs in the setting of cirrhosis. But there is one notorious exception that the exam loves to test.
Right. Hepatitis B can cause hepatocellular carcinoma in a completely healthy, non-cirrhotic liver.
And the mechanism goes back to it being a DNA virus. Unlike hepatitis C, which stays in the cytoplasm, hepatitis B can physically insert its own viral DNA directly into the host hepatocyte's genome.
Specifically, it often integrates near TERK promoter sites, which are genes that regulate cell cycle and proliferation.
This direct insertional mutagenesis overrides the cell's normal checkpoints, driving oncogenesis entirely independently of the fibrotic pathway.
While viral hepatitis remains a global threat, we must also acknowledge the rising epidemic of non-alcoholic fatty liver disease, or NAFLD, progressing to NASH.
The sheer prevalence of metabolic syndrome and severe insulin resistance is driving massive amounts of lipid deposition in the liver. That lipotoxicity triggers inflammation, driving the exact same fibrotic pathway toward HCC.
Because the risk is so high across all these groups, rigorous surveillance is mandatory. High-risk patients require a liver ultrasound every 6 months. We often combine this with serum alpha-fetoprotein, or AFP.
ASP isn't sensitive enough to be a standalone screening tool, but if you see an AFP level surge past 500 nanograms per milliliter in a patient with known liver disease, it is highly specific for HCC.
Once a suspicious nodule is found on ultrasound, you proceed to a triphasic CT scan. What makes HCC unique is that you rarely need a biopsy to confirm the diagnosis.
Which is incredibly fortunate because sticking a needle into the tumor carries a high risk of seeding cancer cells along the needle tract.
You can diagnose it purely on its vascular signature. A normal liver receives 75% of its blood supply from the sluggish, nutrient-depleted portal vein.
But hepatocellular carcinoma is highly metabolic. It undergoes aggressive angiogenesis, building a chaotic network of new vessels to draw its blood supply almost exclusively from the high-pressure hepatic artery.
So when you administer intravenous contrast during the CT scan, it hits the arterial system first. The tumor acts like a hypervascular sponge, lighting up brilliantly during the arterial phase. We call this arterial hyperenhancement.
Seconds later, during the portal venous phase, the contrast finally reaches the rest of the normal liver parenchyma. But by then, the fast-flowing arterial blood has already washed the contrast completely out of the tumor.
So the tumor appears dark against the bright background of the normal liver. Arterial hyperenhancement, followed by rapid portal venous washout in a cirrhotic patient, is the definitive radiological hallmark of HCC.
If the tumor is caught early and the patient has preserved liver function, surgical resection is an option. However, for many patients with underlying cirrhosis, the only definitive cure is to remove the diseased organ entirely through a liver transplant.
Because donor organs are incredibly scarce, eligibility is dictated by strict oncological guidelines known as the Milan criteria.
Right. To qualify for a transplant, a patient must have one single tumor nodule that is 5 centimeters or less, or are up to 3 separate nodules that are each 3 centimeters or less.
There can be absolutely no macrovascular invasion and no spread outside the liver.
If they meet those criteria, a transplant offers excellent long-term survival. For advanced disease that falls outside those boundaries, we rely on systemic targeted therapies.
Drugs like sorafenib or lenvatinib are multi-kinase inhibitors designed to starve the tumor by blocking the very angiogenesis that feeds it.
Mastering these physiological connections, knowing exactly why furosemide alone triggers hepatorenal syndrome, recognizing the core IgM in the hepatitis B window, understanding how free copper shatters red blood cells, and visualizing the arterial blood flow of an HCC tumor will elevate your exam performance from rote memorization to true clinical reasoning.
I want to leave you with a physiological paradox to think about as you study. The liver is the only solid organ in the human body capable of dramatic regeneration. You can surgically resect up to 70% of a healthy liver, and it will grow back to full size.
It's wild. Yet it is this exact miraculous ability to heal the relentless generation of regenerative nodules and the laying down of collagen to repair injury that ultimately creates the portal hypertension, chokes off the blood supply, and provides the fertile ground for cancer.
It really forces us to ask if end-stage liver disease is truly a failure of the body's defenses, or if it is the tragic result of the healing process working way too aggressively.
A toxic success in a way.
It's a humbling reminder that sometimes pathological damage is just the body trying way too hard to survive a chronic insult. Keep questioning the mechanisms behind the symptoms, trust your clinical logic, and we'll see you on the next deep dive.